Next up, we are going to have another panel. We are going to have a panel discussing public policy and the governmental response in a pandemic, lessons learned, and the impact on people with disabilities. It is my pleasure to welcome back from his discussion this morning, Daniel Dawes, as the moderator of the panel. Daniel, I'll leave it to you. Thank you.
All right. Well, thank you so much, Jonathan, for that kind introduction. And let me just say good morning again to everyone and welcome. I want to thank each of you for joining our panel, Public Policy and the Governmental Response in a Pandemic, Lessons Learned and the Impact on People with Disabilities. You know, I am very delighted to moderate today's important session and discuss how we can eliminate compounded disparities for people with disabilities, address the political determinants of health that have created and perpetuated these inequities, and affect the systemic and structural changes we so desperately need in our communities. You know, there is no denying the fact that COVID-19 has changed everyday life for all of us in a multitude of ways, as we've seen, and that our country's experienced a moment of racial and social reckoning. As the death toll reaches nearly 600,000, the COVID-19 pandemic has laid bare inequities within all of our systems, right? And our society at large. People with disabilities and those from communities of color bear an unequal burden. As researchers have recently reported, these groups are more likely to contract the disease, 3 times as likely to end up in the hospital, and almost twice as likely to die from it. A recent study published in the New England Journal of Medicine found that intellectual disability was second only to older age as a risk factor for dying from COVID-19. And in fact, the results showed that those with intellectual disabilities were 2.5 times more likely to contract COVID-19, were about 2.7 times more likely to be admitted to the hospital, and almost 6 times more likely to die from the infection than the general population. You know, when we layer race and ethnicity, socioeconomic status, and other intersectional factors, you know, it paints an even more frightening picture. So in the midst of this tragic moment in history, we recognize the reality that throughout our entire history, we have never been able to realize an equitable response when pandemics or epidemics have struck the United States. This is going all the way back to 1793 when yellow fever struck Philadelphia, all the way up to our present time with COVID-19. You know, it's always undeniably the same group of people who are on the downside of advantage and opportunity and power, who are most negatively impacted: lower socioeconomic status communities, people with disabilities, immigrant communities, racial and ethnic minorities. Today, we aim to identify and eliminate the barriers that are preventing the advancement of health equity during this COVID pandemic, along with best strategies and practices that leaders in the field have put into place to move the health equity needle forward. We're going to specifically discuss how policy can fix what policy created in the first place. So I'm excited to dig deep into some of these topics and learn from each of our panelists. So without further delay, let's begin our discussion. I'd like to ask our panelists to turn on their cameras at this time. We have a lot of ground to cover, and we are so fortunate to have 4 of the brightest, most innovative, and forward-thinking minds in public policy to help us better understand and address the challenges and opportunities moving forward. So now it's my distinct honor and privilege to introduce our esteemed panelists. And then we're going to move into the question and answer segment. So today we are joined by Dr. Fabienne Larocque, who serves as the medical director of the New York City Department of Homeless Services, followed by Victor Calise, who serves as the commissioner of the New York City Mayor's Office for People with Disabilities. Then Dr. Michelle Morse, who serves as the deputy commissioner for the Center for Health Equity and Community Wellness, as well as the chief medical officer for the New York City Department of Health and Mental Hygiene. And then, of course, Andy Imperato, who serves as the executive director of Disability Rights California, and also a member of the Biden-Harris COVID-19 Health Equity Task Force. I want to thank all of you for joining us today. So why don't we begin by each of you telling us a little bit little bit more about yourselves and the incredible work that you've been doing to address the compounded inequities for people with disabilities. Fabian, why don't we start with you, then followed by Victor, Michelle, and then Andy.
Hi, good morning, everyone. Thank you very much, Danielle. Again, as you said, my name is Fabienne Larac. I am the Medical Director of the Department of Homeless Services. First, let me thank the organizers for inviting me to be part of this important program. For those who cannot see me, I have brown skin, lots of curly hair. I'm wearing a dark suit and a white shirt. For those who can't hear me, I have a French-Haitian accent. I'm a Haitian immigrant. I'm sitting in front of a red brick wall in Brooklyn, New York. I use the pronouns she and her. Just to show a bit of data on our system, DHS serves a large homeless population. And on May 5th of this year, there were almost 50,000 shelter clients at the DHS facility. Of those, over 27,000 were in families with children, including over 15,000 children, and almost 18,000 were single adults. In addition, we serve almost 4,000 persons experiencing street homelessness. Among shelter clients, over half, 56%, are Black, non-Hispanic, and a third are Hispanic, mirroring what you heard from Dr. From Virginia, from Correctional Health. Our population tend to mimic that of correctional health. In fact, the correctional system feeds directly into our shelters, which compounds our issues. Shelter times vary between self-contained private units and shared living area for single adult, but we have several shelters with accessible features, including elevators, ramps, first floor units, etc. In addition to being homeless and suffering from deep poverty and trauma, a high proportion of our clients have very limiting medical, chronic medical and behavioral health conditions. They have disabilities when they arrive at our doorsteps. 2/3 overall have a medical or behavioral health condition, whereas among single adults, almost half have a chronic disabling medical condition. 40% have mental illness, and a third express substance use related conditions. In terms of disabilities, also 2/3 have a disabling condition that impact their capacity. 1/3 have a condition that requires specific appliances or medical equipment, and 18% have difficulty with mobility. So as you can see, our clients are at high risk for getting COVID-19 due to difficulty distancing, and also at high risk to suffer complication from the infection because of their comorbid conditions. This timeline showed how we responded. We responded immediately to the announcement of the COVID pandemic. By the time the first case was diagnosed in one of our clients in early March, we had already begun disseminating guidance on screening and infection control. We started distributing protective equipment, although as was mentioned before, we didn't have enough. And we opened our first isolation hotel mid-March, which is very early, specifically for our client diagnosed with COVID-19. By April, we were distributing specific guidance for our shelters with 3 or more cases of COVID-19 to give them stringent infection control information. We started relocating thousands of clients from our congregate setting into density hotel, finalizing the relocation of close to 10,000 people in June. By then, we had opened 4 more isolation hotels with more than 500 beds for our clients with COVID-19. And we started on-site systematic COVID-19 testing in May at all our congregate sites. By June, we started working with the New York City Department of Health and Mental Hygiene on contact tracing and started quarantining contacts in newly opened quarantine hotels. In January, we started offering COVID-19 vaccination, and in the middle of last year, we started systematic testing at our intake site. So what else did we do, and what were our accomplishments? Although the situation was extremely difficult also for our clients, similar to the correctional system and to the rest of New York City, we modified our service provision protocol quickly to facilitate access to our services. We were the first New York City agency to open a COVID-19 isolation hotel for our clients. We, as mentioned before, we strategically relocated clients out of congregate shelter to density hotel to allow for physical distancing. We offer reasonable accommodation for single room to clients at high risk of complication. We increased significantly placement options for clients with unsheltered homelessness. We use data and analysis to track and change our intervention as needed. We continue our strong effort to comply with ADA standard, all the while maintaining all existing services and bringing services to clients. While New York City closed, DHS never closed. Our frontline staff were always there. Our shelter were always open. We continue to work throughout and to work even more to make sure that our clients did not miss a bit of our services. In terms of COVID-19 testing, our proactive testing rolled out in May 2020, and we are continuing to offer testing every 4 weeks religiously to all congregate sites. We are testing in about 200 sites a month and about 1,200 clients per week. Our on-site testing model with a contracted medical provider made it certainly easier for our clients, whether they have mobility challenging, intellectual challenges, or just chronically ill, to get testing at their shelter. Our on-site proactive testing tended to identify many clients without symptoms who could then be immediately identified and isolated while their contact were quarantined, resulting in decreased transmission and infection. As of last week, we are testing approximately 4,000 to 6,000 people per month. Overall, we tested more than 50,000 clients in our congregate shelters and more than 12,000 at intake. At the last complete round of testing, only 2% were positive. We started vaccinating our clients in January, merely a month after the vaccines were approved. The Department of Social Services started a point of dispensing in January, offering the Moderna 2-dose vaccines. At that time, DHS brought its client to the vaccine via prearranged transportation and brought them back for the second dose, thereby facilitating access. As of May 7th, over 5,000 persons were fully vaccinated at that site, including over 4,400 staff and almost 1,000 clients. Then vaccination began in early March on site at all our congregate sites with the 1-dose Johnson & Johnson vaccine via the mobile medical provider that had been providing testing every month. Therefore, we brought vaccine to the clients at their shelter inside, thereby facilitating access even more and prioritizing clients for this 1-dose vaccine. To date, overall, we have fully vaccinated over 5,500 persons at with the mobile providers, including 1,500 staff and almost 4,000 clients. The total number of clients fully vaccinated by DHS via both methods, almost 5,000, is an underestimate because it doesn't include vaccination by our contracted medical providers or received elsewhere in the city. We are in the process of starting a match of our data with the citywide immunization registry to get a true vaccination rate for our clients. Overall, I'm happy to say that the race ethnicity of our vaccinated clients matched that of our clients in general, with over 50% of Blacks and 29% Hispanic having been vaccinated, this demonstrating that in terms of vaccination, we are keeping equity. This last slide shows the epidemic curve among DHS clients. Ultimately, DHS's effort resulted in overall infection rates lower than the city's average, an epidemic curve matching the city curves with increase and decreases as the rate increases and decreases in the city, with a mortality rate only slightly higher than the city average, even though we have a population with a high rate of chronic medical conditions, demonstrating the success of our effort. All that was made possible because it takes a village. Our leaders, Jocelyn Carter's, all our deputy commissioners, our first deputy commissioner, really worked tirelessly to support our client and to support our frontline workers who, again, never stop working. And with that, I will close and thank you very much for your attention again for this invitation.
Thank you so much, Fabienne. And let me just interject quickly before we go on to Victor. If we could speak a little slower for our interpreter services, that would be really appreciated. So Victor, what?
I'm sorry, I tried that.
No, I understand. I'm guilty too.
Great. Thank you, Daniel. Thank you, everyone, to the panel. I am a white male with longish salt and pepper hair with glasses, wearing a blue blazer and a striped blue shirt. Thank you again for everyone for being here. It's great to be here in Zoom. And as Fabienne said, New York City did close, but New York City government didn't. And we were here all that way, making sure that people understand what was happening. It was scary. It was a scary time. And as everything started to roll out and we became the epicenter for coronavirus, many people with disabilities were scared. They didn't know where to turn, who to go to. And we quickly pivoted to holding weekly calls for the community, making sure that they understood everything that we understood. Making sure that the digital platforms were accessible for people with disabilities. We were making sure that during emergencies, we had a sign language interpreter during Superstorm Sandy till today, till the time Corona hit, and that really served us well. We made sure that we had captioning in every step of the way, that people with disabilities had the right resources that they needed. And I tell you, I was scared. Everyone was scared. And finding the right information and getting it out there was crucial. We had hundreds and hundreds of people on our call, and through the pandemic, and we're still holding those calls today. Making we pivoted to monthly calls, but we know what that did for the community. And John Novick, as you has been our moderator for this whole conference, he has been extraordinary through this process, and we owe him a debt of gratitude here. This is Jonathan's last day, and I want to say, Jonathan, thank you for all your support, because people depended on you, as did our office, and you did a fabulous job in providing those services. And some of the services that we did provide, a lot of food insecurity. We were delivering that food, making sure that people with disability had access to that, making sure that the forms that they were filling out were accessible for people with disabilities, making sure that we can bring food to people's house and actually get it into their apartments. Protective equipment was a big issue. We had standard forms that were set up and delivery mechanisms specifically to people with disabilities, making sure that home care workers were defined as essential workers. In the beginning, that was scary because people with disabilities relied on them, and making sure that they had the proper safety, protective equipment as well. Those were all right in the beginning of the pandemic. And transportation for people with disabilities. The Access-a-Ride Hour paratransit really set up a one-ride system so we can get people safely, because they were scared to ride public transportation or be with people they didn't know. And then making sure those that had COVID-19 were able to get to the hospital and get the transportation they needed. So that was all important in the beginning stages. And making sure that we set up real-time information on our website. It was constantly updated with new information, working with Department of Homeless Services, working with the Department of Health and Mental Hygiene, all through this was critical, because we're just one agency. And we knew that that disability intersected with all those other agencies, working with emergency management, working with information technology, making sure that it was there and they knew we were there, that we knew we were on top of them, demanding accessibility at every step of the way. And we never once did we not have captioning, never once didn't have sign language interpretation on all the mayoral press conferences. And that still continues to happen today, because we know information is, and accessible information is key. We held vaccine equity strategies and included racial inclusion and equity efforts. We had community messaging, as well as city employee volunteers that certainly we were training to make sure that they understood what accessibility is. Vaccine recovery, right? I mean, COVID recovery as well. Digital accessibility, online tools used to secure vaccine appointments, making sure they were accessible from the get-go, and then making sure that we were constantly updating them, because we realized that things changed and those that needed to be accessible as well. Expanding transportation options for people with disabilities, making sure that homebound vaccinations included people with disabilities and their caregivers as well. We assisted our health department on eligibility of people with underlying conditions, pushing to make sure that we analyze things over and over, and having redundancies put in so that we can make sure that everything we were doing had that equity and intersection for people with disabilities. So that's just a little bit. I know we're going to go through this conversation, Daniel, so I'll stop there and turn it over. So thank you for your time.
Thank you, Commissioner.
And I hope that was slow. New Yorkers talk real fast, so it's a little hard for us every once in a while.
Right. Oh, no, we understand. And thank you so much. It sounds like you have been extremely busy. So Dr. Morse, your turn.
Thank you so much. Thank you, Daniel, for facilitating, moderating, and setting us up for a really powerful conversation. It's good to see you. And just honored to be here with the other panelists as well to just, again, continue to elevate this issue. I want to start by just briefly introducing myself, since I'm a new face in the New York City city government. Again, my name's Michelle Morse. My pronouns are she, her, hers, and I'm a Black woman wearing a blue and white blouse and blue and red earrings, and I have short brown hair. Again, just want to thank the organizers for curating and setting up this conversation and discussion. As I mentioned, I just recently joined the New York City Health Department as the agency's first ever chief medical officer, and also as Deputy Commissioner for the Center for Health Equity and Community Wellness. And I've been, of course, doing a lot of thinking about the impact of the COVID pandemic on individuals and communities nationally and globally, as well as around awareness of what was broken before the pandemic and how this pandemic has made us see things that we haven't always wanted to see about ourselves. So I see this also as a time where this is an important opportunity for us to push even harder on how things could be and change what was before. I myself am an internal medicine doctor and a hospitalist, and I work part-time as a hospitalist at Kings County Hospital. And I've also worked for many years as an internal medicine provider in Massachusetts, as well as in Haiti. So I share that with Dr. Larac. And unfortunately, I have seen the negative impacts of delayed and denied care on individuals, families, communities here in New York City, in Massachusetts, in my hometown in Philadelphia, as well as in Haiti, Rwanda, and other places. And it's painful to acknowledge how that common thread exists in all of those settings. And I think it's so important to highlight, and it's already been highlighted by Dr. Larac and the other panelists as well, how important it is for us to take an intersectional lens when we're looking at these issues. Of course, for the Center for Health Equity and Community Wellness, we've been examining and acting on racial inequities in health outcomes for several years now. But we have to be looking at how racial inequities intersect with disability justice, with other systems of oppression, and focus our attention on the communities and people in New York City and around the world who have shared identities and unfortunately suffer from the interlocking systems of oppression that shape their opportunities and their health. I think it's really, really important to also acknowledge how this pandemic has shown us that people with disabilities, even before the pandemic, were more likely to be report being treated poorly or denied care. Again, even before the pandemic, and that has been even more amplified during the pandemic. Reports of physicians deprioritizing care of the disabled has also been a pre-existing issue prior to the pandemic. And clinics and hospitals and office spaces that are inaccessible to people living with disabilities, as well as denial of accommodations, of necessary and needed and just accommodations. So this is the reality pre-pandemic. And again, it was even more clear and painfully clear during the pandemic. But I think it's really important to acknowledge the work in the health department around accessibility for our vaccination sites. As you all know, much of the vaccination work happened very, very quickly in terms of building out infrastructure for vaccination to be available in sites across the city, some run by us at the health department, others run by the state and the federal government, and of course, the existing healthcare infrastructure. And as quickly as some of that work happened, we have to acknowledge, I think, at the health department that we didn't act quickly enough for some of the necessary accommodations. And I want to just highlight that our teams have been working to fix some of those challenges. Most importantly, I think I should highlight that currently, all of our appointment making websites do meet accessibility standards. Appointments can be made online and over the phone. And there is now finally an option for people living with disabilities to request accommodations at our vaccination sites through our Vax for NYC appointment scheduling website and our call-in line. And we also do now have our Vaccine Finder website with an icon and a filter for identifying physically accessible sites. I would say that this is important work, but it's not enough. And we want to keep on ensuring that disability justice is central to all of our work on health inequities at the health department in general, but especially at the Center for Health Equity and Community Wellness. And I think we have much more to do in that realm to live up to those values and standards. Finally, I just again want to thank you for the opportunity to speak about this and underline again that advocacy, both inside and outside of government, and coalition building across public, private, and nonprofit sectors can really allow us to bring our systems forward and make sure that we are having a positive impact for individuals with intellectual and developmental disabilities. Thank you again, and back to you, Daniel.
All right, thank you, Michelle. Really appreciate those remarks. And Andy, your turn.
Thank you, Daniel, and thanks to the organizers for having me. I'm coming to you this morning from Sacramento, California. I am a 55-year-old white male with glasses and short hair, and I'm wearing a blue shirt and a dark burgundy blazer, and I'm delighted to be with you all this morning. So the hats that I wear relevant to this discussion, as Daniel mentioned, I am a member of the Health Equity Task Force along with Octavio. He and I are on a subcommittee together working on communications and collaboration, and I've really enjoyed getting to know him and work with him in the context of the task force. I'm also the head of the Protection and Advocacy Agency in California, which is called Disability Rights California, free legal services for people with all types of disabilities across the state of California. And I during the pandemic, I've served on our community vaccine advisory committee for the state of California that has met regularly and helped the state think about prioritization and deployment and readiness for people related to vaccines. So I just want to mention a few things that happen in California. Oh, and my pronouns are he, him, his. Just a few things that happen in California that I think are relevant to this discussion. I know this has been mentioned by earlier speakers, but our experience with crisis standards of care was bumpy. We had the California Department of Public Health issued draft guidelines for the whole state on how to implement crisis standards of care that we felt were discriminatory. They basically said, it's okay to deny somebody a ventilator if they're too old or too disabled to benefit from the ventilator. And we worked with the Disability Rights Education and Defense Fund and a group called Justice in Aging, which is a national group but has a big presence in California, to push back on those standards. And the state, to their credit, came out with new standards in June, new guidelines in June that did not discriminate on the basis of disability or age, and that we felt were dramatically better. But California is a progressive state. California was thinking about equity from the beginning of the pandemic. So the fact that our state Department of Public Health came out with guidelines without running it by the disability community or advocates for older adults and had to be kind of publicly criticized, to me is an indicator that we have work to do as a state to really understand what equity means from a disability rights perspective and from the perspective of older adults. Another example was around vaccine prioritization. Our state announced in early February that they were going to do everybody over 65 before they did anybody else. And at that point, they weren't sure how quickly they would get to the whole over 65 population, and they were predicting it may take them until June. Obviously, we now know that that was a conservative prediction that didn't play out. But we argued strongly that there were high-risk people with disabilities who were under 65 that should not have to wait until June to get a vaccine, and that people would die unnecessarily if the state stuck with that prioritization system. Again, to their credit, the state listened to us and they started vaccinating high-risk people with disabilities under 65 on March 15. But again, I think the fact that we had to have the back and forth with the state was another indicator that the folks who were making the decisions, mostly physicians connected to our Department of Public Health, did not have deep knowledge of the disability community. And they used the fact that we didn't have great data about risk and disability and COVID against us on the issue of whether we would be prioritized for vaccines. And we felt that that was a double equity problem. The fact that we didn't have good data was not our fault. It was an equity problem that we didn't have the data. And then they were using the lack of data against us on prioritizing folks for vaccines, which, you know, is a life and death issue for a lot of people. So I bring this up not to be, you know, unduly critical of the state of California, because I don't think these problems are unique to California. I think that the culture of public health does not have deep knowledge of disability. And, you know, in California, we have an Office of Emergency Services. I know Commissioner Calise has done a lot of work around emergency preparedness and response. I would say one of the things that we need coming out of this pandemic is we need our public health infrastructure to learn more how to integrate people with access and functional needs in the context of a pandemic or anything else that the public health infrastructure is focused on, and to have people with lived experience with disabilities as part of their organizations. You know, we have Cal OES, the Office of Emergency Services, has a chief for access and functional needs. There's not a position like that in the California Department of Public Health, and there needs to be. At the national level, the CDC has a National Center on Birth Defects and Developmental Disabilities. That center needs to be elevated. The perspective needs to be elevated, and they need to have more people with lived experience with disabilities working there, giving them an insider view on how to listen to and address the needs of people with disabilities in the future. So I just bring those up to say, this pandemic uncovered problems. Our state, to their credit, learned and listened to the disability community and got better. But we had fights during this pandemic that should not have been fights. And I think part of the reason they had to be fights is because people with lived experience and deep disability knowledge were not at the table when initial decisions were being made.
Well, thank you, Andy, you know, for speaking truth to power and bringing in that data piece as well. You know, what I heard today is you all have shared, you know, the experiences, you know, or what you've seen in terms of the inequities affecting people with disabilities. And Peggy in the chat box actually brings up a pretty interesting question that was tied to the question I was going to ask you all to think about. So what do you think needs to happen in the next year to achieve equity for people with disabilities and their families? And Peggy, let me just, you know, merge out with Peggy's question, where she says the data presented brings up a point that we have a tendency to present data as the solution rather than simply a tool to use. And the information data provides is essential. History, however, shows us that it is not government that embraces and initiates changes in policy and practices in which discrimination is deeply embedded. It is the people who face discrimination that have led the rest of us to make land accept legislative policy. So I guess make and accept legislative policy and practice changes. For example, the ADA, IDEA, ABA, et cetera. Do you have any information or thoughts on how these diverse minority groups may be joining together to create or sustain a movement aimed at erasing barriers to access of healthcare, transportation, housing, and employment, et cetera? And Victor, I know you had talked a lot about these various social determinants of health. Why don't we start with you and then go from there?
So I want to echo what Andy said, right? If you don't have people with disabilities working on these issues, you're not going to have that disability representation. The reason why we've been successful in the city of New York, number one, is that I'm battle tested because I've been through Superstorm Sandy and a lot of shelter redesign and accessibility and a lot of transportation issues because an office like this exists. And we have disability access functional needs coordinators in our emergency management department. How we got there is another issue, but we need to be proactive instead of reactive. And far too long, government has been reactive to things. I'd like to think that we were on top of everything, but we weren't, because we need more of that disability representation. We've done that in lots of ways, making sure that we have disability service facilitators that are in agencies across the city that are advocating for the rights of people with disabilities in design and construction. And what we see now even more are programs and services, making sure that we're part of legislation when that comes out and making sure that we're embedding disability across every piece of that. I mean, transportation is a big issue, all of it. I mean, and you know, we've been hearing about this and you heard me say intersectionality. What does it mean? It means that disability is part of Department of Health, Department of Cultural Affairs, part of Department of Transportation, part of Parks and Recreation. The list goes on, and we don't have that representation. It doesn't work. And you know, as we look at the future of what healthcare is, it needs to be embedded completely. We have to look at telehealth and make sure that the access we have now isn't a regression, right? Because right now people with disabilities can access things, but this digital world that we're in now is wonderful, but we're leaving people behind because we have created a digital divide for people with disabilities that just doesn't work. We need municipal Wi-Fi, right? So people can have this. We need to be able to have connected devices so people can have this. This is not the have and have nots. We just need to make sure that disability intersects with everything that government is doing. And that's our job. And that's what we do to ensure that New York City, A, is the most accessible city in the world and that nobody is left behind.
Love it. And how about, can anyone speak to Peggy's question about, you know, how we can bring these diverse minority groups together to create or sustain a movement aimed at erasing these? How do we do that? How can we do that?
Well, I'm happy to go if nobody's jumping in. This is Andy. I guess fundamentally, I think part of what we need to establish as kind of an expectation is that we're not going to have conversations about disability equity without talking about racial justice issues within the disability community and beyond. And we're not going to have conversations about racial equity without thinking about the unique issues for people with disabilities who are part of all these other groups. So, you know, when President Biden signed the executive order creating the task force, he had an opportunity to define equity. This is the COVID-19 Health Equity Task Force, to define equity in a way that clearly included disability as part of equity, not disability just as a bad health outcome that we're trying to avoid, but disability as a demographic group that experiences discrimination and disparities based on their status as people with disabilities. So to me, that set the tone. First day in office, you know, he created an equity lead within the Domestic Policy Council, Catherine Lehman, who came from California. She's now been nominated to be the Assistant Secretary for Civil Rights at the U.S. Department of Education. She has a deep history of integrating disability into all of her roles. So, and now she has Kim Knackstedt at the White House, who's focused on disability, but again, under this equity pillar within the Domestic Policy Council. So I feel like the feds are teeing up for us an ability to have this intersectional conversation, not to have a separate conversation about equity and race, and then a separate conversation about equity and disability. But that needs to happen at all levels of government. And frankly, the disability community needs to take more seriously the racial justice issues within our community. We've been trying hard at Disability Rights California to prioritize intersectional issues in our advocacy. And sometimes we get pushback, people telling us, stay in your lane, you don't need to comment on things that aren't disability issues. And we say all of these racial justice issues are disability issues. And if we don't address them, we're leaving out populations within the disability community. So I just think it's a culture change that's happening, and that in the disability movement, if we want to build these broad movements, we need to take more seriously the justice issues within those movements that play out within the disability movement. At the national level, the Leadership Conference on Civil and Human Rights has been working for years to build this kind of broad intersectional coalition. But we need a Leadership Conference on Civil and Human Rights in every state, in every major city. I mean, it can't just be at the national level. These kind of broad coalitions need to come together everywhere decisions are getting made that affect us.
Great point. Michelle, I see you're off.
Oh, yes. Sorry, and Fabian wanted to add something as well.
Fabian, okay, I apologize. I saw Michelle first, and I saw Fabian.
Space for everybody. Yes, absolutely. Yeah. I'll be very, very brief. I just wanted to lift up how important Peggy's question is. I think it is the question. And I'm just so thankful that she posed it and that you lifted it up in facilitating, Daniel. And then the response that I just wanted to put forward in just the very short term, right, is at least in the COVID pandemic, what we're seeing right now is a sustained decrease in rates of COVID positivity in New York City, which is exciting. But we are already, of course, thinking about what an emergence and reemergence and, change in rates of COVID is going to look like this fall and winter. And to Andy's point about crisis standards, we can make the crisis standards conversation different for this fall and winter now, right? I mean, if we're talking about access and we're talking about disability justice and we're making sure that those things are all connected with racial justice as well, that conversation doesn't have to be the same this fall and winter as it was last fall and winter or when the pandemic started. And I think that there are great examples of how we can make that conversation different and ensure that it is racially just and aligned with disability justice now. I think that conversation starts now. So just very concretely for Peggy's question, I think part of the answer is we don't repeat the mistakes. And that's how we can make sure that government is trustworthy and proposes a new vision and is responsive to the concerns of our citizens. So that's all I wanted to mention.
And reaching out to communities, we talk about this, and we noticed that some of the data that we were looking at, and data is really important. I think I heard Shirley talking about data earlier, that we need real data on people with disabilities, right? We know a lot of people with disabilities don't self-disclose for obvious reasons, but using data is important. And when we use data, prior to the pandemic, we noticed that in Black and brown communities, disability was high, white community was high, and then Asian communities, it dumped off considerably. We're talking, a big dump, and we were trying to figure out why. And we were reaching out to the Asian communities and saying, how come we're not involved? And we started to do more of that outreach to Asian communities, disabled Asian communities, and say, hey, we need you in this umbrella. We need you part of this conversation because we know the numbers are higher than actually being represented here.
Thank you, Victor. Fabian.
Hi, thank you. I do agree. I wanted to mention something that Andy said. Public health doesn't really understand disabilities, and I have to agree with that. I mean, I've been a public health specialist for over 20 years, and I think I'm not a disability specialist, and that hasn't been on my radar. And you ask, what can we do in the next year? I mean, I make a promise that we're going to look at disability some more. And that is not to say that the Department of Social Services is not doing an amazing job Our own planning committee member, Jennifer Shaw, is the director of disability affairs, but I promise that, Jennifer, you're gonna see more of me. You're gonna hear more of me. And one of the things that we do, and in my office, it's a mini public health office at DHS. We use data and we collect data a lot. So I do agree also with Victor, data is not the answer, but data is the beginning of the answer. If you don't analyze the data, you don't know what's going on. We would never know that our #1 cause of death at DHS is opioid overdose if we didn't analyze the data. We wouldn't know that before COVID, heart disease was #2. We wouldn't know that we had people dying of heart disease at age 35, 40 if we didn't look at the data. So what we do with the data is really what's important. So I would love to do a survey of our clients. We've been talking to clients, so we are giving them a voice. So one of the things that we would really like to do, or I'm just getting that idea percolating in my head, is to talk to our client with disability and do a survey and see how we could help them further.
All right,
Daniel, I just want to jump in here too, and I think it's government's role to understand what disability is. Right now, we know that there are lots of trainings that happen with diversity trainings, and they happen with sexual harassment trainings in city government. So we are working on making sure that we have disability training across city government as well, so people can understand what that actually means. Because we as government need to be able to serve the people. I mean, as we talk, when the mayor came in many years ago, he talked that the people that work for the city should look like the city as well, and we need to make sure that people with disabilities are reflected in that and things like that as well.
Wonderful. So, thank you so much to our audience. We're getting a lot of wonderful feedback. Jennifer says, thank you, Victor. We have amen from others, and they really are appreciating the sage advice that you're providing. Fabian talked about it starts with us, right? And I'm so glad to hear that a part of that is this greater interagency collaboration, right? As a next step. Michelle brought up that, one of the things that we should really think about is don't repeat the mistakes of the past, right? As a tangible way to move forward. And so, we've talked a lot today about political determinants of health. They've obviously played a huge role in the spread of COVID-19. Now, do you anticipate policy change in the aftermath of COVID-19 to build more resilient communities? And what types of changes would you advocate for other than what we've talked about? Where should we start? Who wants to take that one?
Well, I don't have an
Michelle.
answer exactly, but I do have a few ideas. And again, that is the question. That is the question. The thing I'll offer up immediately is, yes, I do expect policy changes, #1. And I think that is, as was already described by other panelists, part of that is the new conditions, directions, and priorities that are being set by our new federal administration. I think that is obviously already a huge step forward, but I'm thinking about what are some of the policy changes from the perspective of provider engagement and how providers, and I have to, of course, just acknowledge myself as an internal medicine doctor, we are not trained in the biomedical model to give appropriate time, respect, attention, and pragmatic work towards disability justice. In fact, we are trained in a system that really promotes ableism without acknowledging that it's there, undergirding a lot of our medical education. And again, I'm going to speak about physicians because I'm a physician, but I know this is true for other health professions as well. So in terms of policy changes, I know that I've seen a lot of momentum from the ACGME and the AAMC, both of which are organizations that have an important policy role in how physicians specifically are trained and held accountable. And I hope that that will continue to be an area for policy change. How is ableism talked and tracked in medical curricula, and how is it changed? How do we change how we train the next generation of physicians and other health professionals so that those mistakes are not repeated? I hope that there is going to be policy change in that realm, and I hope that physicians, whether there's policy change or not, step up to what we're being called to do in this era, to re-examine our profession, to re-examine how systems like ableism are rooted in it, and to decide for ourselves that it has to change. That's where a lot of policy change, especially for physicians, comes from. So, and I hope to see what we can do in the health department side to support that as well.
I love that you brought that in, and Tuara just mentioned that our collective definition of disability has to be broad enough to acknowledge and be responsive to all causes of disability, no matter the source. Let me pivot now then. I want to go a little further upstream. Some may argue that an equity in all policies agenda is exclusively a liberal agenda. How do you frame messages such that they are democratizing and not polarizing across party lines, such that whatever policies promoted will achieve the primary goal of the policy and uphold equity tenets? Curious to hear your thoughts on that. How do we work?
I'm happy to go first on that.
Yes, please, Andy.
I was in Washington for 26 years working with Republicans before I came to California. And we do have Republicans in California too. They just don't have as much power as they do in Washington. But I think employment is an important unifier. You get very broad political support for the idea that people with disabilities deserve to participate in the labor market. And I think if we can build an equity agenda to try to get the people who were displaced from the labor market during COVID back into the labor market and help, as Victor said, every level of government should be a model employer for people with disabilities. So government should lead the way. We're having a similar event to this next week, where our governor recorded a video and talked about how he wants California to be the model employer for people with disabilities. Well, let's roll up our sleeves and do that. There's no reason that can't be bipartisan. And then I also think we haven't talked a lot about what happened to people in congregate settings during COVID, but the disability community has been fighting a fight for years to get people out of nursing homes, out of congregate settings, and into the community. I think that is a bipartisan issue because it's about freedom, and Republicans like the word freedom. And to the extent that we can really frame this as both from a public health standpoint, saving lives and avoiding risks associated with congregate facilities, but also giving people the ability to have the kind of freedom in their lives as adults that other people take for granted, I do believe that that's something that we can get bipartisan support for.
Yeah, I'd echo Andy on the employment initiative, right? People with disabilities live in poverty. We need to be able to pull them up. Work is certainly a way through that. Redesigning our Medicaid process, our buy-in programs for people with disabilities and how they can still maintain their benefits and work, which is a big issue for people with disabilities. Really, the idea that Republican, Democrat, disability doesn't care. Right. There's Democrats and Republicans both with disabilities and it's real to them. And that's what we need to be able to focus on, that disability is part of everyone. And we could tackle this by making sure that we can get rid of those biases that are in the healthcare profession, making sure that we go to the social model and realize that people with disabilities don't need to be fixed. They just need to be cared to and for their specific needs and what they are. So employing people, breaking down ableism, making sure that we're all part of government in every way, I think are the ways forward, and real, true, inclusive education. Well, with that, Victor, we are out of time, but let me just... Okay, Fabian, take 30 seconds, quick.
30 seconds. I really wanted to emphasize education, because I think education of people with disability will give them opportunity in the future, but also education of the rest of us to understand people with disability and end segregation in school and elsewhere. I think is really important.
Thank you. Yeah. Thank you. So let me just close out our panel by thanking each of our distinguished guests for the privilege of your time. We want to thank all of you viewing this session for joining us today. And I hope that you gained some new insights on the challenges and the opportunities for advancing justice and health equity that this moment in our history provides. Thank you all again for joining us.
Thank you everyone so much for your insight and your experience on this panel. Daniel, thank you for moderating. And yes, I think everyone can agree with so many of the concepts of, we need to be proactive and not reactive. We need to take the lessons that we've learned and make sure this does not happen again. And now I'm speaking very quickly, so I apologize.